Hi, hello everyone. Welcome to Dr. Ravichandra Official. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos on pathology. All of you know this is a picture of normal peripheral blood smear. There will be red blood cells, white blood cells, and platelets in a peripheral blood. What are the hematopoietic organs? So, the hematopoietic organs are yolk sac, liver, and bone marrow. Yolk sac will be the predominant site of erythropoiesis from 2nd to 10th week of gestation, and the liver will be the predominant site of erythropoiesis from 10th week to 24th week of gestation. From 24th week, bone marrow will be the predominant site of erythropoiesis. From 24th week to till birth, bone marrow throughout the skeleton will be helpful in erythropoiesis, whereas from birth up to puberty, bone marrow throughout the skeleton is the predominant site of erythropoiesis. But after puberty, that is after 16 to 18 years, the erythropoiesis is restricted to few places of bone marrow. That is, erythropoiesis is restricted to bone marrow of vertebrae, ribs, sternum, skull, pelvis, and proximal ends of humerus and femur. Simply remember the predominant sites of erythropoiesis will be yolk sac up to 10th week of gestation, liver up to 24th week of gestation, and from 24th week it is bone marrow. And after puberty, few areas of bone marrow only will show erythropoiesis, that is vertebrae, ribs, sternum, skull, pelvis, and proximal ends of humerus and femur. That's why we are doing bone marrow aspiration and biopsy mostly in the sternum or in the pelvis iliac crest. From a hematopoietic stem cell, progenitor cells will be arising, that is lymphoid stem cells and myeloid stem cells. From the lymphoid stem cells, prolymphocyte will form. From the prolymphocyte, from the thymus, T lymphocytes will form. From the B lymphocytes will be forming from the bone marrow. Natural killer cells will be forming from the bone marrow from a prolymphocyte. Myeloid stem cells are trilineage cells. They will give rise to granulocyte monocyte precursors, erythroid precursors, and megakaryocytes. From the megakaryocytes, platelets will come. From a single megakaryocyte, around 16 platelets will be forming. From erythroid precursors, RBCs will be formed, and granulocyte monocyte precursors will give rise to neutrophils, eosinophils, basophils, and monocytes. So, what I have told in the illustration earlier is depicted in the diagram. So, pluripotent stem cell or hematopoietic stem cell will give rise to myeloid stem cells and lymphoid stem cells. Lymphoid cells will form or convert into prolymphocytes. From the prolymphocytes in bone marrow, B lymphocytes will be formed, and from the thymus, T lymphocytes will be formed, and from the prolymphocyte from bone marrow, natural killer cells also will form. And from the myeloid stem cells, megakaryocyte progenitors will be formed. With the help of thrombopoietin, platelets will be formed from a megakaryocyte. And from erythroid precursors, erythropoietin hormone will help in formation of the red blood cells. And from the granulocyte monocyte precursors, granulocyte monocyte colony stimulating factor will help in formation of neutrophils, basophils, eosinophils, and monocytes. CD34 is the marker for the stem cells. So, as I said in the earlier slide, stem cells will give rise to progenitor cells. From the progenitor cells, linear committed precursors will form, and from the linear committed precursors, mature cells will be formed with the help of various interleukins and other factors that will promote the maturation or formation of a mature cells, and that will be released into the blood from bone marrow. Coming to erythropiesis. From a bone marrow, as I said earlier, hematopoietic stem cell which is multipotent. From that, granulocyte myeloid precursors will be formed. From that, granulocyte monocyte precursors will be formed. And from that, myeloid progenitor proerythroblast will be formed. This proerythroblast is also called as pronormoblast. Here, hemoglobin will be formed first in the proerythroblast. This can be asked in MCQ or your NEET exam. From the proerythroblast, there will be formation of a basophilic erythroblast, and from the basophilic erythroblast, it will be polychromatic erythroblast. From the polychromatic erythroblast, orthochromatic erythroblast is the next stage. So, proerythroblast is also called as pronormoblast, and basophilic erythroblast is also called as early normoblast. Polychromatic erythroblast is also called as intermediate normoblast, and orthochromatic erythroblast is also called as late normoblast. From the late normoblast, there will be enucleation and resulting in the formation of a polychromatic erythrocyte, which is called as reticulocyte. From the reticulocyte, after 24 hours, erythrocytes will be formed. So, in the stage of erythropoiesis, it is the journey from bone marrow to blood, from multipotent hematopoietic stem cell to erythrocytes. If you observe the picture, it is clearly saying that the size of the nucleus and the cell is decreasing from the precursors to erythrocytes, and the nucleus is removed from the precursor, resulting in the formation of erythrocyte. So, as we go from proerythroblast to normal RBC, there is reduction in size and there is nuclear condensation. Nucleus will be extruded from the late normoblast, resulting in the formation of a reticulocyte. So this is a picture showing erythropoiesis, various stages: proerythroblast, basophilic erythroblast, polychromatic erythroblast, orthochromatic erythroblast, reticulocyte, and mature red cell. Mature red cell will be of size of 7.2 microns, and it is like dumbbell shaped or biconcave, and there will be central one-third pallor, which is common for a red blood cell. When there is central normal one-third pallor, it is normal. Then the cell, if it is of size of 7.2 microns, which is equal to the size of a small lymphocyte, it is called as a normocyte. As central one-third pallor is present, it is called normocyte, normochromic red blood cell. So the size of a red blood cell will be around 7.5 microns, which is almost equal to the size of a small lymphocyte. Then it is called as an normocyte. If the size is less than 6 microns, it is microcyte. And if it is more than 7.5 microns, more than 9 microns, you can say it as a macrocyte. Based on the color, red blood cell can be called as normochromic or hypochromic. In a normal red blood cell, there will be central one-third pallor, that is one-third of the diameter, there will be pallor. So hypochromasia means the central one-third pallor is increased. So more than one-third of the cell will be showing pallor. Then it is called as hypochromic. Coming to anisocytosis, variation in the size of a cell, red blood cell, is called as anisocytosis. Change in the shape or variation in the shape of a red blood cell is called as poikilocytosis. So, a red blood cell can show anisocytosis and poikilocytosis based on the etiology. The poikilocytes can be spirocytes or drepanocytes or dacrocytes or ovalocytes or elliptocytes or acanthocytes or echinocytes or sickle cells or bite cells, so, so on. So, anisocytosis is variation in the size of red blood cell and poikilocytosis is variation in the shape of the red blood cells. With this brief introduction, today we will start the topic of what is anemia and what is the classification of anemia. Define and classify anemia. This is the competency that we are going to discuss in the further slides. What is anemia or define anemia? Anemia is defined as a state in which the blood hemoglobin is below the normal range for the patient's age and sex. It means with a number you can't tell whether the person is anemic or not. You should tell the age of the person and sex of the person. If you say it is hemoglobin 12, if you are not saying the age or sex, you can't say whether the person is anemic or not. If you say, suppose hemoglobin is 12, if the person is a male one, definitely the normal hemoglobin value will be around 13. So he is anemic. For suppose if the person is a female and her hemoglobin is 12, then it is normal. Okay, clear? So anemia is defined as a state in which the blood hemoglobin level is below the normal range for the patient's age and sex. According to World Health Organization, hemoglobin less than 10 gram per deciliter is considered as anemia. In children, the hemoglobin will be around 12 gram per deciliters in between 11 to 12. Up to 4 years, it is 11 and more than 11, and up to 12 years, it is more than 11.5 normal, and up to 15 years, it is more than 12. So less than these ranges are considered as anemia. In adult men, the hemoglobin should be more than 13. If it is less than 13, then it is called as anemia. In a non-pregnant woman, the range is hemoglobin should be 12 gram per deciliter. If it is less than that, then it is considered as anemia. In a pregnant woman, the lower limit is reduced in pregnancy, so the hemoglobin will be around 11 gram per deciliter. So less than 11 gram per deciliter in a pregnant woman is considered as anemia. Anemia can be graded into mild, moderate, and severe based on the hemoglobin value and clinical presentation. It can be mild or moderate or severe. So mild hemoglobin range will be 9.5 to 13 gram per deciliter. Often there will be no signs or symptoms. Commonly, the patient or the person will be remaining untreated. Moderate anemia is hemoglobin ranging between 8 to 9.5. The person may present with symptoms, requires management to prevent the development of complications. Severe anemia is less than 8 gram per deciliter. Symptoms usually will be presented at the time of patient visiting the hospital. It may be life threatening and requires prompt management. Classification of anemia. Anemia are classified based on the cause of anemia, which is called as etiological classification or pathophysiological classification. And there is one more classification based on the morphology of red cells. It is called as morphological classification. So anemia are classified based on the etiology. It is called as etiological classification. And if it is based on morphology of red cells, it is called as morphological classification. Etiological classification of anemia is broadly divided into it is because of the cause may be anemia of blood loss or decreased production of red cells or due to excessive destruction of the red cells. Anemia of blood loss, it can be acute or chronic. The causes of acute anemia of blood loss are trauma, major surgical procedures, and postpartum bleeding. Whereas chronic anemia of blood loss is due to hookworm infestation, bleeding peptic ulcers, carcinoma colons, IBDs, hemorrhoids, and excessive menstrual loss. Anemia due to decreased production of red cells is can be because of the nutritional deficiency. Iron deficiency will affect hemoglobin synthesis. Vitamin B12 and folate deficiency will affect the DNA synthesis. Inherited genetic defects. These defects will lead to stem cell depletion, resulting in Fanconi's anemia. Defects affecting the erythroblast maturation, which are called as thalassemia syndromes, and erythropoietin deficiency because of the anemia of chronic disease or renal failure. Immune mediated injury of the progenitors will result in hypoplastic or aplastic anemia and PRCA, pure red cell aplasia, PRCA. Marrow invasions like leukemias, lymphomas, secondary carcinomas, and granulomatous disease will cause the decreased production of the red blood cells. Inflammatory iron sequestration in anemia of chronic disease will also cause decreased production of the red blood cells. And there are various unknown mechanisms that will end up in decreased production of red cells leading to anemia. They can be endocrine disorders like hypothyroidism, hypoadrenalism, hypopituitarism, and in some cases of hepatic disease. Anemia due to excessive destruction of red blood cells, also called as hemolytic anemias. These can be because of the genetic disorders or acquired disorders. Genetic disorders that will cause excessive destruction of red blood cells will be there may be a red cell membrane defect leading to hereditary spherocytosis like conditions, enzyme abnormalities like G6PD deficiency, hemoglobinopathies like sickle cells and thalassemias. Acquired disorders can be immune mediated or toxic injury or mechanical and infectious causes that will be causing the excessive destruction of the red blood cells, thereby causing anemia. So, this is a slide showing a nutshell or basic mind mapping of etiological classification of anemia. So, it is broadly divided into anemia of blood loss, decreased production of red cells, and due to excessive destruction of red cells. These are further subdivided based on the cause. Now coming to morphological classification of anemia. Based on the size and color of the red blood cell, this classification has been done. It can be normocytic normochromic anemia or microcytic hypochromic anemia and macrocytic normochromic anemia. When the red blood cell indices MCV, MCH, and MCHC are less than their normal lower limits, then it is microcytic hypochromic anemia. When the MCV is more than 100 femtoliters and the MCH is within the normal range and MCHC is around 30 to 35 gram per deciliter, then it is called as macrocytic normochromic anemia. And in normocytic normochromic anemia, MCV will be within the normal limits 80 to 100 femtoliters. MCH will be within the normal range and MCH will be 30 to 35 gram per deciliter. So this is a picture showing the morphological categories of anemia. First picture is showing microcytic hypochromic anemia. Second picture is showing macrocytic anemia. And third picture is showing normocytic normochromic anemia. In a peripheral smear, first you have to identify a small lymphocyte because the small lymphocyte size will be 6 to 8 microns. So the red blood cells which are equal to the size of a small lymphocyte are considered as normocytic and less than the size of 6 microns are considered as microcytic and more than 8 microns, that is 9 microns, is considered as macrocytic and one third central, one third pallor is considered as normochromic and more than one third of the diameter of a red blood cell, if pallor is there, then it is called as hypochromic. Now coming to symptoms of anemia. The acute symptoms can be shortness of breath, organ failure, or shock. Chronic symptoms can be generalized symptoms or with hemolysis or with defective erythropiesis. General symptoms will be because of the tissue hypoxia. Fatigue, lassitude, dyspnea, palpitations, dizziness, headache, syncope, tinnitus, vertigo, irritability, sleep disturbances, lack of concentration, paresthesias, anorexia, nausea, bowel disturbances, cardiac failure symptoms, amenorrheas, and polymenorrheas. These all will be because of the tissue hypoxia resulting in anemia. And with hemolysis, there will be expansion of the marrow resulting in skeletal abnormalities, growth retardation, jaundice, and gallstones because of the hemolysis. With defective erythropoiesis, there will be iron overload, which will cause heart and endocrine failure. Now coming to signs of anemia. The commonest sign of anemia will be pallor. Pallor of the skin and mucous membranes, nail beds, and palpebral conjunctiva. Next, there will be tachycardia with a wide pulse pressure, ejection, systolic murmur, which will be best heard over the pulmonary area. There will be cardiac dilatation, and in later stages, there will be signs of cardiac failure, and edema is common. So, symptoms of anemia, acute and chronic, and signs of anemia, the most commonest is pallor. So, this is a beautiful picture showing how to identify a normal person from a person with anemia, whether there is pallor or not, whether there is any retinal hemorrhages or not, whether there is glossitis or not, angular stomatitis is there or not. You have to check all this for anemia. And if there is hemolytic anemia, you have to even check for jaundice. And in macrocytic anemia, you have to check for the bald tongue or beefy red tongue. And in iron deficiency anemia, there may be esophageal webs, and in hemolytic anemias, there may be a hair on end appearance or crew cut appearance on X-ray. Consequences of anemia: reduced function and quality of life, decreased survival, increased risk of heart failure, changes in the neurological functions, and complications from the surgery, coronary deaths, and decreased tolerance to chemotherapy are the consequences of anemia. With a clinical feature, you can diagnose a probable cause for that anemia. If there is a history given like this: pregnancy, females of reproductive age group, growing children, definitely they will have nutritional deficiency. Chronic blood loss, most of the times the probable cause will be iron deficiency. In chronic alcoholism, there will be definitely folate deficiency. Sometimes gastrointestinal blood loss may happen, and sideroblastic anemia also seen in few cases. Ingestion of drugs. By prolonged intake of the aspirin, there will be iron deficiency from gastric bleeding, and usage of cytotoxic drugs will end up in aplastic anemia because of the marrow invasion. Alpha methyl dopa and rifampicin like drugs will result or end up in autoimmune hemolytic anemias. And with the family history of anemia, jaundice, gallstones, or splenectomy, you can know the probable cause as inherited hemolytic anemias. And if you examine the person or the patient, if there is hepatomegaly, splenomegaly, or lymphadenopathy, definitely there will be hematological malignancy. And in the history, if it is given as Sindhis and Lohanas, mostly these people will be suffering from thalassemia. Parsis and Prajapatis, they have glucose 6 phosphate dehydrogenase deficiency. Tribal groups are mostly suffering from sickle cell disease. And if there is history of skull deformities or facial deformities like malar prominence, frontal bossing, depressed bridge of nose, if you observe this, then definitely there is a chance for thalassemia. So, in the exam, by the history itself, you will be able to give your probable diagnosis. And with the investigations, with the results, you can come to the exact diagnosis, and it will be helpful in managing that person. So, in exam, the question can be given as: a female of 40 years who is presently having 4 months of amenorrhea came with a complaints of shortness of breath, lassitude, lethargy, frequent headaches. When her hemoglobin was checked, it was around 10 gram per deciliters. What is your provisional diagnosis? It is nutritional deficiency. So, anemia classification, morphological classification: microcytic hypochromic or normocytic normochromic or macrocytic anemias. Microcytic anemias will be because of, it can be sideroblastic anemia or iron deficiency anemia, thalassemias, anemia of chronic disease, lead poisoning, porphyrias, all will end up in microcytic anemia. Remember the mnemonic: Sita or Seetal or Lista or Pistol. Sideroblastic anemia, iron deficiency anemia, thalassemia, anemia of chronic disease, lead poisoning, and porphyrias. Coming to the macrocytic anemias, in alcoholics, liver disease, endocrine problem like hypothyroidism, megaloblastic anemia because of the folic acid and B12 deficiency. Usage of cytotoxic drugs like methotrexate and other drugs like phenytoin will end up in macrocytic anemia. The mnemonic will be LHMC: liver disease, hypothyroidism, megaloblastic anemia, and cytotoxic drugs. Or you can remember as A, B, C, D, E, F. A for alcoholics, B for B12 deficiency, C for cirrhosis of liver, D for drugs like methotrexate and phenytoin, E for endocrine problems like hypothyroidism, and F for folic acid deficiency. With this, few anemias have been diagnosed. If the blood picture is normocytic, normochromic, then you have to advise reticulocyte count. If the reticulocyte count is low, then the normal range for that age group, that is in the children or in the adults. Okay, you can think of renal failure, anemia of chronic disease, myelofibrosis, or cancers. For this, the mnemonic will be for low reticulocyte count. You can call the mnemonic as Ramchandra or Ramco cement, RAM-C, or CRAM, cancers, renal failure, anemia of chronic disease, and myelofibrosis. With this, few diseases have been diagnosed. Still, if the reticulocyte count is high, then it can be sickle cell anemia or hereditary spherocytosis or autoimmune hemolytic anemias or PNH, paroxysmal nocturnal hemoglobinuria, or enzyme deficiencies like G6PD deficiency. Remember the mnemonic shape: sickle cell anemia, hereditary spherocytosis, autoimmune hemolytic anemia, and paroxysmal nocturnal hemoglobinuria, and enzyme deficiencies like G6PD deficiency will show high reticulocyte count and normocytic normochromic anemia in the peripheral blood smear. So, with this knowledge, let's test what is your diagnosis. These are all the questions that have been given in your previous Dr. NTR University of Health Sciences or your KNR UHS pathology paper 1 question paper as a essay. A 55 years old lady presented with progressive fatigue and tiredness for last 1 month. She also complained of tingling and numbness in the lower limbs. On examination, she had pallor and her tongue had a glossy appearance. So, pallor, tongue glossy appearance, tingling and numbness in the lower limb, 55 years lady with progressive fatigue. All are suggesting of a diagnosis of anemia, and that too it nutritional anemia. It can be B12 and folic acid. With investigation, you will conclude mostly it is because of B12 deficiency, as tingling and numbness in the lower limbs will be present mostly in the B12 deficiency cases. And there is one more characteristic point: glossy appearance. So the diagnosis is macrocytic anemia. It can be megaloblastic or non-megaloblastic. In the megaloblastic, it can be B12 deficiency or folic acid deficiency. And with the investigations, you can confirm it as B12 deficiency anemia. 1 year old child is admitted with increasing pallor, so it is anemia since the age of 2 months. There is pallor, hepatosplenomegaly is there, and hemoglobin 7.2. So it is a hematological malignancy or hemolytic anemia. A 48 years old male presented with a pallor and easy fatigability. He complains of a sore tongue and tingling in hands and feet, and there is partial gastrectomy 3 years ago for gastric ulcer. So the stomach has been removed. So there will be absorption problem. So it can be nutritional anemia because of the folic acid deficiency, B12 deficiency, iron deficiency. So you have to advise further investigations and diagnose the disease. Mostly it will be as the history is giving partial gastrectomy and tingling in hands and feet, it is macrocytic anemia because of B12 deficiency. 3 years old child presented with pallor, growth retardation, and history of repeated blood transfusions. Child is having splenomegaly and mild jaundice. Skull X-ray is showing hair on end or crew cut appearance. It is a classical case of hemolytic anemia. 35 years old female presented with fatigue, weakness, glossitis, and peripheral neuropathy. Peripheral neuropathy because of B12 deficiency. So it is a macrocytic anemia due to B12 deficiency. A 30 years old pregnant lady who cherishes to eat food prepared by boiling, steaming, and frying presented with anemia, glossitis, mild distress, history of diarrhea, loss of appetite, and lack of well being. No evidence of nervous system manifestations. Her serum homocysteine levels are elevated but not methylmalonic acid levels. So it is showing pointing towards macrocytic anemia. You have to rule out the B12 deficiency and folic acid deficiency. So here the clue will be homocysteine levels are elevated but not methylmalonic acids. 35 years old female presented with anemia, glossitis, and neurological manifestation. So it is macrocytic anemia because of B12 deficiency most of the times. 40 years old male presented with weakness, fatigue, and dyspnea, having spoon-shaped nails, complaining of recurrent bleeding piles. Hemoglobin is 2.5 gram per deciliter. So it is severe anemia, and it is because of the bleeding piles, which is a chronic condition, and it is recurrent, and there are spoon-shaped nails, which is called as chylonychia. So it is a classical case of microcytic hypochromic anemia because of iron deficiency or anemia of chronic blood loss. So it is a microcytic anemia. DD will be sideroblastic anemia, anemia of chronic disease, thalassemias, iron deficiency, lead poisoning, and so on. So this a 30 years old female presented with anemia, loss of sensation, and tingling in the feet. Examination showed smooth tongue with atrophic papillae, that is ball tongue, large tongue, okay, macroglossia, and B12 deficiency with loss of sensation and tingling in the feet. So it is a case of macrocytic anemia. A 3 years old girl from the West Bengal presented with pallor, growth retardation, and history of repeated blood transfusions. There is small occlusion of the jaws with skull X-ray showing hair on end appearance and hepatosplenomegaly. Hemoglobin was 3.5 gram per deciliter. It is a severe anemia because of the hemolysis, excessive destruction of the red blood cells, thereby causing skeletal deformities and hepatosplenomegaly. So it is a case of hemolytic anemias. 25 years old female with a history of 4 months amenorrhea complaining of mild jaundice, anemia, and glossitis. So she's a pregnant lady. So mostly it can be B12 deficiency or folic acid deficiency. That is end up in macrocytic anemia. That's why minimum supplementation of 100 iron and folic acid tablets is advised for a pregnant woman throughout the course of the pregnancy to avoid anemia in pregnancy. Thank you for your patient listening. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos.